Welcome back to Rebelcast. I'm your host, Salim Rizai. This is episode 117. The topic, low dose versus standard dose, take home buprenorphine from the emergency department. Now, before I bring on not one, but two guests to introduce themselves, I just wanted to do a little something here at the beginning. So this paper got sent to me, and initially I thought, man, what a garbage paper. I mean, from a statistics standpoint and in terms of like clinical applicability, in terms of what their results were, I wasn't really that impressed. But then on second read, I went through it and I really am fascinated by this concept. And I was so fascinated by it that I thought this is definitely something we should talk about because number one, I've never even heard of this. I work in a community setting, not an academic setting. And two, I figured if I haven't heard about this, maybe there's a ton of other people that haven't heard about this. And so it's worth discussing. So with that, that is my 2 cents on the paper. So if you're looking for a lot of stats and randomized clinical trial and all this, you're not going to get any of that on this episode. But I would still keep listening because I think this is something that could potentially change your practice and how you deal with these patients. So with that, let me introduce our first guest, Dr. Kara Borelli. Kara, welcome back. Thank you for doing this again. Do you mind just telling the listeners where you work and what you do?
Yeah, hi. So I am an addiction medicine fellow. I did my emergency medicine training in San Antonio, and now I am at Icahn School of Medicine at Mount Sinai in New York City.
Well, thank you for taking the time to do this. And then our second guest, who's a first time Rebelcaster. And is this your first time podcasting too?
It is 100%.
Okay. Well, this is Dr. Tara Holmes. And Tara, why don't you tell the listeners who you are, where you work, and what you do?
Yeah, so I'm Tara, and I'm a first-year resident at Mount Sinai Morningside West Emergency Medicine program, and I'm hoping to do an addiction medicine fellowship in 2 short years.
Well, welcome both of you, and thank you for doing this and humoring me because most people are just going to hear me asking a lot of questions and sounding silly. You guys are going to be the meat of this episode. So with that, before I go on, one last thing. Tara, thank you for doing all the heavy lifting on this. You're the one that kind of did this paper, kind of like critiqued it and then sent it to Kara. And then through the both of you, you sent it to me. So thank you for doing that. So I want to make sure you get credit for that.
Oh, thank you. Definitely a group effort.
Okay, so let me get us started. So first of all, why are we talking about opioids and medications for opioid withdrawal? One of you take that for us.
So, as we know, opiate overdose is a leading cause of death in our country, and it's been a problem that's been increasing over the years. Even just from 2019 to 2021, in 2 years, we've seen an over 60% increase in deaths. The reason why we care about this, and as emergency medicine physicians, is because a lot of these patients come into the emergency department at some point during their struggles, with opiate use disorder, and it's a great point for us to start and induce treatment, and we can save many lives doing this in the emergency department.
Yeah, I agree. And I have to say, like with the COVID pandemic, I feel like this is something we're seeing more and more of, not just with opioids, but even like alcohol and other substances. But this has definitely increased. I remember the days of only seeing it. Maybe one or two like heroin overdoses, but now you're getting like all these like fentanyl and their derivatives and a whole bunch of other stuff. So I think this is a very timely discussion. Now, Kara, there's two possible ways to treat that I'm aware of, and you can correct me if I'm misspeaking, treating opioid withdrawal. Those are buprenorphine and methadone. So can you just quickly give the listeners a reminder of how one works versus the other?
Yeah, so methadone is a full mu opioid agonist. Unfortunately, there's some limitations in terms of how patients can access it. If they're getting it for opioid use disorder, they have to get it through an opioid treatment program. They have to go into a clinic to get this treatment. So it has that barrier to receiving treatment. Whereas buprenorphine, now the X waiver was recently eliminated, so you don't have to go into a clinic daily like they would have to with methadone.
Yeah, that was really huge because I remember there was. I mean, I'm not sure if you remember, Kara, but we had to do this like 8 hour like online thing, and then we had to fill out all this other paperwork before we could even prescribe it. It was like they had just put up so many hurdles; it was like impossible to give. So I'm
Yeah.
glad that they removed that.
Yeah, there's been a lot of changes with COVID. So they've relaxed some of the methadone guidelines in terms of patients not having to come in quite as frequently, but it's still a major undertaking for patients to go into clinics so regularly. So buprenorphine can be a really great option for people.
So, Tara, you said the ED is a nice point in identifying these patients, and I agree because the ED is the catchment area of everything in this country. Like, we get social problems, we get domestic problems, we get medical problems. So, it seems like this is an easy access point to find these patients. Now, I've seen several of these patients, and it seems like when we do standard dosing buprenorphine, it we're not supposed to prescribe it until they're like in moderate or severe withdrawal. And I've seen a lot of people have like bad experiences because of that and are absolutely against even doing it again. And so I was wondering what your thoughts are on that, what your experiences are with that, and then maybe Kara, you could chime in after.
So, for me personally, I mean, obviously, I'm interested in addiction medicine, so I'm always advocating starting and sharing resources with my patients that we have in the emergency department. And buprenorphine is one of those things I always bring up with my patients if it's something that they're interested in. And a lot of my coworkers and attendings, they don't know that you don't need an X waiver anymore. So I even try to share that with them. But I'm having so much trouble getting through this barrier that patients need to be in withdrawal, especially because so many times my patients come in, maybe they had just used an opiate and they're interested in stopping, but they don't want to go through the withdrawal. I mean, that's part of the reason why they continue to use. So they don't through withdrawal. So having the withdrawal component be necessary for the standard dosing induction of buprenorphine is a huge barrier, whether you're in the ED or in the outpatient setting.
Okay, Kara, next one's for you. So we know that this is a barrier, right? The having to be in some sort of moderate to severe withdrawal before using the buprenorphine. Now, this paper we're getting ready to talk about uses this terminology called microdosing of buprenorphine, which is what I called low dose at the beginning. And so I know some people use those interchangeable, but I guess first of all, why don't we start with what microdosing or low dose buprenorphine is? And then maybe you could give us just a little 2 sentence on why it's such a huge division in people using one term versus the other.
The low dose buprenorphine is when you start with a very low dose as opposed to your standard dose that you would start with, which is 4 or 8 milligrams. You start with a fraction of that, typically around zero point 0.5 milligrams of buprenorphine. And then you slowly increase this over time instead of starting with a higher dose like 4 or 8. Then the terminology low dose versus microdosing, some people don't think that the term microdosing has is reminiscent of the term that people use for psychedelics and don't like to have that association. So it's a different people have different preferences based on terminology, but they're referring to the same concept, which is starting with a very low dose of buprenorphine instead of the typical dose.
So here's what I've taken away so far from our conversation, and then we can start digging into this paper. So, ED is a great way to identify these patients. Clearly, this problem is increasing, and we're seeing more and more deaths. Secondly, buprenorphine is easily accessible, it's available, and it's safe based on the evidence that we have for it. The next step, I think, is keeping patients from rebounding or losing them to follow up. And that's where I find this concept of the microdosing or low dose buprenorphine really fascinating because I think that's like the holy grail, right? You identify them, you give them something that's safe and not expensive and is not going to be harmful, but then also keeping them on track. And so that's why I wanted to talk about this. And so with that, Tara, can you start with what paper are we covering?
Yeah, so we're covering Mo et al. So it's microdosing and standard dosing take-home buprenorphine from the emergency department and a feasibility study. So basically, it's a study before what we hope will be a randomized controlled trial, investigating whether this would be a feasible study or not.
And Kara, what's the clinical question they were trying to answer?
The clinical question is to compare low dose take-home packages of buprenorphine compared to standard dose packages.
And then Tara, why don't we talk a little bit about what they kind of did? Because there was a couple phases in this trial.
Yeah, so there were two phases in this trial. So initially, identified patients based off their inclusion/exclusion criteria, which will be in our written notes. But phase one, this was not a randomized phase. They basically voluntarily enrolled patients into the standard dose group. So initially, they got 15 patients in the standard dose. So that's what Kara was talking about. The standard dose in which patients are required to be in moderate withdrawal before starting the standard dose buprenorphine. So after they got 15 patients into this group, they started enrolling more patients into the low dosing group. So they actually got 17 patients in the low dosing group. But again, this is all voluntarily by the patients. So patients in this group, they received a 6-day take-home package of buprenorphine, at the low dose, and they could start this at any point in their experience after the ED. So they could start that either while they're in the ED, and they can also concurrently continue using the opiates they were using. Whereas with the standard dose, they would have to be in moderate withdrawal and not use at this time. So obviously that's one of the barriers that we were talking about, the withdrawal and inability to use. But with the low dose, they were able to continue to use their opiate and didn't have to be in withdrawal. Phase two was to determine whether randomization of the sample was possible. So phase two involved recruiting another 14 patients, this time randomizing them in a 1-to-1 ratio, either to standard versus a low dose group. In both of these phases, patients were offered symptomatic treatment, so for nausea and for any body aches or anything, so, Zofran, ibuprofen, as they needed it. And they had, they were referred to like low barrier, no cost addiction clinics available to them 7 days a week. In 7 days, they were followed up via telephone, and also again at 30 days with $10 and $20 incentives, respectively.
And then I'm going to leave the low dose induction protocol that they were using in the show notes, because I think anybody who's interested in doing this and wants to know kind of what the dosing strategy was, I think it's really helpful. So if it's something you want to start doing at your institution, you have something that you can follow and there's some evidence to support it. As far as inclusion/exclusion criteria, we'll also leave those in the show notes. And then, Kara, what were our primary and secondary outcomes of this study?
The primary outcomes were the number of patients enrolled and the acceptability of randomization. The secondary outcomes were number of patients screened, number of patients contacted at follow-up, and 30-day opioid agonist therapy retention.
All right, let's get into the results. So 68 patients consented and enrolled out of 94 eligible, right? So it's about just over 72%. And 26 of the 94 eligible patients declined participation with reasons including prior negative buprenorphine naloxone experiences, fear of withdrawal, current disinterest, feel no need for assistance at this time, preference of morphine, and preference to choose dosing strategy. Those were all the reasons that were given as to why those patients declined. When we look at the characteristics, I think this is pretty standard across the country. I'm sure there's always variations to this depending on where you live, but the mean age were people in their mid-30s. About a third of the population was homeless. Over 85% were unemployed. 52% were white, and 21% were Hispanic. The predominant presenting complaint was substance misuse intoxication, localized swelling or redness, and overdose ingestion. And as far as what types of opioids were we dealing with, about 28% was heroin, about 56% was fentanyl, which is pretty much what I'm seeing where I work at. Not sure how it is for you two, but that's exactly what we're seeing. And about 80%, so 4 out of 5 participants, had previously already tried an opiate agonist therapy for withdrawal. So, Tara, what did they find in phase one?
So in phase one, they also saw that a percentage, somewhere around 25% of participants left against medical advice, particularly because of long wait times, because initially they were requiring urine toxicology testing to confirm whether there was opiate use or not. So this was considered the rate limiting step. So in phase two, they eliminated this requirement, and after that, 0 participants left AMA without this without long emergency department waits.
I wish I
know that
could get
was
rid of urine toxicology. Like that was like the happiest thing I read in this paper. Like that was the one thing I wish I could get rid of, but I'm sorry, I digress.
Yeah, so then they also discussed follow up. So in phase one, at the 7-day telephone follow up, 12.5% of people followed up, and at 30%, at 30-day follow up, 31.3% of participants followed up. And in phase two, 7-day follow up, which was via text message instead of phone, increased follow-up to 35.7% of participants. And then at the 30-day follow-up in phase two, it was 35.7% who followed up. So with the standard dose induction, 30-day follow-up was 23.8%, and the low-dose induction follow-up was 32%.
Yeah, so it was better with the low dose induction, which is why I found this paper so fascinating. Kara, we don't need to go through all the strengths and limitations, but I'm wondering, as an addiction physician, what were some of the strengths that impressed you and what were some of the limitations that bothered you?
One of the strengths was I haven't been able to find randomized trials about low dose buprenorphine versus standard dose buprenorphine. This is something that is already being used quite regularly in the inpatient and outpatient side. For example, when I admit people to the hospital, I'll be doing the low dose buprenorphine induction for most patients. And then when I'm in clinic and I'm inducing someone on buprenorphine, almost always I'm using the low dose induction. But there wasn't research that I could find comparing them in an RCT. So this is something that's leading towards that research being done, which is, I think, very, very exciting that we're finally going to get some data on this. This study, I really like the idea of the take-home packages because that seems to be a very intuitive way for patients to understand. I've had patients, even though I give them handouts on how to cut the strips or the tablets, some patients just seem to really struggle with understanding how many to take on which day, even with cute little graphics that I have handouts of. Whereas having like a blister pack, I think that this is a really great idea and a great way for the patients to understand what they're doing.
All right, Tara, basically it looks like this study, although can't prove statistically that this is the case, it looks like trends are toward microdosing having better results in follow-up than standard dosing of buprenorphine for opioid withdrawal. So what were the main discussion points for you, Tara, that kind of people should hear about in regards to this paper?
All right. So as we discussed, the study investigated whether individuals would feasibly participate in a trial with the two dosing groups, so microdosing versus standard dosing. And it also investigated whether randomization into either group would be possible. The major takeaway for me is that more people followed up with the low dose group because it removed this major barrier requiring patients to experience withdrawal before starting buprenorphine, and at the same time they had the comfort of being able to continue to use their opiate while transitioning into their treatment. Another finding that was, I think, important for us to have identified in this preliminary phase is that something as simple as the urine toxicology, increasing wait times in the ED being a barrier for patients to follow up. After removing that barrier, 0 people left AMA, which I think is huge as well, and can help incentivize people who were deterred from standard dosing buprenorphine to actually maybe consider trying low dose buprenorphine.
If only it was this easy in real life,
I
like
know.
let's just get rid of urine toxicology. This is my rant, get rid of urine toxicology screening. Anyways, Kara's probably cringing.
No, I'm there's so many problems with urine toxicology screenings.
Mm-hmm.
All right. And then Kara, there was something we were talking about before I hit record, and I wish I would have recorded it. So because I didn't, I'm going to make you talk about it again. And that was kind of what's happening in British Columbia with opioid withdrawal and addiction. And I thought it was really fascinating. And you taught me something. You always teach me something, but you taught me even something more.
Opioid withdrawal in British Columbia, they have many other options that we don't have available in the United States. In the United States, we're not allowed to use full opioids for opioid use disorder other than methadone or buprenorphine, which is the partial agonist. Whereas in British Columbia, it's an interesting, different practice climate. So they recently decriminalized possession of small amounts of opioids, such as heroin. Also, they have another option for treating opioid use disorder, which is a version of morphine. They also have some pilot programs where they're doing what they call safer supply, because a lot of overdoses are because people don't know what they're actually using. They don't know how much heroin they're using, how much of it has fentanyl in it, what the percentage is. So they're what they call safer supply programs where they give prescription opioids such as hydromorphone or heroin.
I found that really fascinating. And then the last thing is there is an RCT underway for this, isn't there?
Yeah, so that was probably the coolest. When I was doing research on this paper, the coolest thing that I stumbled upon was, the same author, Jessica Moe, Dr. Jessica Moe. She who did this study. She is now conducting an RCT, a multi-center open-label RCT in 4 different emergency departments in British Columbia, actually doing this study. So comparing the effectiveness of low dose versus standard dosing take-home buprenorphine from the ED. So the study actually began in July of 2021 and is supposed to be completed in 2025, estimated over 600 participants. So I'm definitely very excited into seeing the results of that.
All right, so the author conclusion, and I'm going to quote them. We conclude that enrollment into a randomized controlled trial comparing standard dosing and low-dose buprenorphine naloxone interventions would be feasible in the ED setting, close quotes. Tara, you did all the hard work here. What is our clinical take-home point from this paper?
So our clinical take-home point is that randomization of ED patients to a take-home microdose versus a standard dose of buprenorphine is feasible, and a larger randomized controlled trial would be acceptable for this population, which is being done, which makes me happy.
It makes everybody happy. Kara, do you have any other thoughts, something we haven't touched upon, something I forgot?
No, I just think this is a great option for patients, and I think that the ER is a really great opportunity to provide patients with this option. But very excited for further research on this.
Well, there you have it, Rebel EM listeners. Please leave us your thoughts, comments, and questions. Like I said, this is something new for me, and I figured if I'm out in the community and this is new for me, it might be new for many others. We look forward to your questions, and thanks for always tuning in. Until next time.